Welcome back to the Mayo Clinic Cardiovascular Podcast Series, Interviews with the Experts. I'm your host, Sharon Hayes. I'm a non-invasive cardiologist and Vice Chair of Faculty Development and Academic Advancement for the Department of Cardiovascular Medicine here in Rochester, Minnesota. Today, I'm joined by Dr. Jörg Herrmann, who is Professor of Medicine, Chair of Research for the Ischemic Heart Disease Program, and Director of the Cardio-Oncology Program here at Mayo Clinic in Rochester, Minnesota. So today, our topic is ICI myocarditis. Dr. Herrmann will share with us the evolving use of immune checkpoint inhibitors, or ICIs, and their cardiovascular side effects, including myocarditis, heart failure, and coronary events. He'll also discuss current challenges in the diagnosis and treatment. So Jörg, what are ICIs, and for which diseases are they being used? We know cancer, but maybe there's some other things you want to share.
Yeah, thank you so much, Dr. Hayes, for the introduction. And I'm truly excited to be here and to talk about this topic, which I believe will become more and more important, even for the general cardiologist, even the general internist, because these are really sort of blockbuster drugs, right? I mean, they weren't there a couple of years ago. We didn't learn about them in medical school. And so, yeah, immune checkpoints, what are those? And so I grew up in Germany, right? And it was East and West, and there was this famous checkpoint Charlie. So between East and West Berlin, and you had to show your passport. And if you didn't have any of that flag, you get shot, right? I mean, potentially. And so if you try to intrude. And so it's the same thing with our immune system. And so they surveil and they get activated, but then there are mechanisms in place to keep them in check. And they're on two levels. So the first level is on the level of the thymus, it's the central regulation, and there is a pathway that's called CTLA4. It sounds fancy, but it's just an abbreviation, CTLA4. And so that's one pathway for silencing. And then the other is more in the periphery, and that's the programmed death pathway, PD-1, PD-L1. PD-1 is expressed on T cells, PD-L1, the ligand for it, is expressed on peripheral tissues, including tumor cells. And it's very fascinating that we, Sharon, because we have one of the inventors of this here at Mayo Clinic. His name is Dr. Dong, Dr. Haidong Dong. And so he's from China, and he said he was given this research project. His mentor gave him this research project. Why don't you look at tumor tissue? And he said, so I looked at the tumor tissue, and what I noticed were these black dots around it. And I was wondering, what are these cells and why they're sort of paralyzed? And these were then turned out to be T cells surrounding the tumor and being really paralyzed. So that was, I mean, the PD-1, PD-L1 story that he contributed to. He was not like Jim Allison or Tasuku Honja, who got the Nobel Prize in 2018, but you can see that's where it led. So immune checkpoint inhibitors, to answer your question, I mean, are those pathways that are negative feedback loops built in to avoid overshooting immune reactions? And tumor cells have, in a sneaky way, used this mechanism to silence those tumor-attacking T cells and forego their detriment.
Mainly cancer, and we know that there are side effects. I certainly, this is not something I learned about during training, but when I am covering the consult service at our hospital that houses most of the cancer patients, we're asked to weigh in on this all the time. So yes, it's already affecting us general cardiologists. What are the most common side effects, particularly cardiac, and what do we need to be watching for, or will we be asked to weigh in on?
Yeah, so you might have heard, because as I alluded to, there's a lot of excitement about these drugs, right? For some patients, particularly when they introduced first for melanoma patients and non-small cell lung cancer patients, those were like the biggest groups. There was, a lot of excitement. Christian Barnard, he said this with a heart transplant, right? When are you willing to take such risks? And so if a lion chases you to the bank of a river full of crocodiles, you leap in there gathering that you have a chance to survive, but the odds are very slim. Now, what are the odds of having side effects with these kind of drugs? So some reports would say up to 90% of patients might have immune-related adverse events. And I think when you look at systematic reviews, it might be more than two-thirds have really an immune-related adverse events, and in 15 to 20%, it's severe, clinically relevant. So that's still a fair number of patients, and the most common one are skin-related rash. Second is gut, so diarrhea, colitis. And the third is endocrine, any endocrine organ. So all the itis you can think of, adrenalitis, hypophysitis, thyroiditis, you name it, any itis. And then from a cardiovascular disease spectrum, they're sort of on the lower all there. But nevertheless, myocarditis, has made the news because of its fatality rate. We think it's just 1% of patients who might develop myocarditis with these drugs. But then the fatality rate in the early reports was 60% up to that, in terms of an estimate. Now, we often, particularly early on, when Javed Mosley and others reported on this, it was just two cases, right? Reported in the New England Journal of Medicine. They worked it up very thoroughly, but that was the very tip of the iceberg as fulminant myocarditis. And as it often is in this field, these drugs get rolled out, and then, the most severe cases, they make the news. So fulminant myocarditis we've learned about, but since then we've realized that there is such a spectrum of the inflammatory entities in the myocardium with this. You can have myocarditis, pericarditis, myopericarditis. You can have inflammation of the myocardium without much of myocyte loss. You can have myocyte loss without much inflammation. So there's a whole spectrum. And that, I think, is generating the problem for us on the consult service, or when we see these patients. It's like, how do we interpret this? Because, the common denominator is troponin elevation, isn't it? Nowadays, everyone, and then we can talk later a little bit maybe about these surveillance protocols. Does it make sense? To surveil patients with troponin serially for this possibility, but nevertheless, if the patients show up on our service, or we get even an outpatient clinic because someone checked the troponin, then how do we interpret this? And we got to be aware of the fact that there can also be coronary artery disease. It can be an acute coronary syndrome still. There are some studies suggesting that it's not only myocarditis, that there's an acceleration of atherosclerosis possibly, or vulnerability of atherosclerosis. And then there are arrhythmias that can occur too, SVTs, atrial fibrillation. So you can see those as well. So it's not always myocarditis. And what from animal experiments has come out, and this is from my former place of training in Germany, in Essen. What they found was in mice, it's really hard. They're really resilient to get myocarditis with these drugs. But what they got consistently was cardiomyopathy, especially in the presence of a tumor implanted in these mice. And that's what another group in Leuven, Belgium saw as well. It was not myocarditis, it was heart failure. It was cardiomyopathy that really is something they've noticed. And what was also to a degree concerning is in half of these patients, it was after ICI therapy had been stopped. So there's another dimension to this. It might not be actually right at the time. It might be some delay in seeing these effects. So we always been taught it's coming on through the first 3 cycles of ICI, myocarditis maybe, but cardiomyopathy can be later. And you can also have Takotsubo's, by the way, but I'll let you weigh in, because that was a lot of information already, I assume.
It was. So I think what I've heard from you is there's some really pleomorphic effects, pleiotropic effects on the heart, and we do not fully understand them, and we're still learning. If we focus in on the myocarditis, and you said kind of universally they have elevated troponins, or that's one, but how do we, is this somebody we should be surveilling, or are most of these people coming in sick, and how are we going to approach the diagnosis of this, as opposed to acute coronary syndrome? Just tell us what is your approach to start diagnosing?
Yeah, so I mean, there are different criteria that we've come up with. So the International Cardio-Oncology Society, and then it went into the European guidelines, European Society of Cardiology guidelines, where we developed the definition of ICI myocarditis. There was a prior grid of probable, possible, and definite myocarditis that folks have come up with. The usual players for both of these are the biomarkers, are the ECG changes, are the imaging studies, and then the clinical syndrome. So I think often it starts with a clinical syndrome, but myocarditis is sometimes really hard to pinpoint. Sure, you can have some chest discomfort, but what else is there? I mean, arrhythmias have been some of the leading points, right? I mean, you can have, I mean, the first case we've seen here, that was classic. That person had alternating bundle branch block, complete heart block, non-sustained VT. I mean, the whole spectrum of what you can see with these arrhythmias and an expression of the irritability of the myocardium, but you may not see that. I mean, atrial fibrillation, we've looked at that. It may signal some inflammation, but it may not. It's not like a perfect predictor of that's being present. Now, the chances of this do go up if patients, for instance, have myositis. And then there's the neurotoxicity to this, or the myasthenia gravis. So that's known as the triple M, right? Myasthenia gravis, myositis, myocarditis. That's the triple M. And those patients, they're at high risk of adverse outcomes, including mortality. So that's often, so having some other immune-related adverse events, that really brings up the probability that we're dealing with this. And then from an imaging perspective, we've looked at strain imaging. Sure, there are these reports from registry-based studies that they possibly indicate myocarditis, but they're not perfect. Then cardiac MRI, much to the surprise of many, I mean, that's not perfect either. I mean, so if you have a positive MRI, you're done. But if you have a negative cardiac MRI, that doesn't exclude the possibility of myocarditis still. So the first patient with all the manifestations he had 2 MRIs that were negative. And we've seen other cases too. So Tom Nealon from MGAs, who studied this very carefully, he reported that an initial, so early cardiac MRI might miss it, and a late cardiac MRI might miss it. So there is sort of like an optimum time frame, but how do you pin that time frame? So what the recommendation has been, and I think we may not do this enough, and so that will answer also the question about the value of troponin surveillance, is as a reference, the endomyocardial biopsy, because we've been surprised again and again of these seemingly negative by imaging criteria, even echo not showing much, right? But then the biopsy comes back clearly positive for myocarditis. So I think as a clinician, if you have the smell of myocarditis in your nose, I think you got to pursue it, and you got to be bold and ask your interventional cardiologist if they wouldn't mind doing a biopsy in these patients. Now, you can miss it too, but I think, Sharon, I think you really have to be a little bit more aggressive in some of these cases where everything points to it, but we can't possibly define it.
So biomarkers, imaging, probably sounds like echo and cardiac MRI. And if that gives you your diagnosis, but if not, moving on to tissue evaluation.
Right. Yeah. Yeah. Clearly. And I mean, the biomarkers, I mean, they're likely very sensitive, right? I mean, nowadays, high sensitive troponin, nothing escapes the high sensitive troponin. But the specificity is an issue. And then there's been this debate. I mean, what's better, troponin T or troponin I? Now, I mean, some have their favorites, as you can imagine. Troponin T has some scrutiny because folks have reported that with myositis in these patients, you can have significant troponin elevations alone. And so we use like CK has been used, AST, ALT, these are all liver enzymes that are also AST expressed in the muscle. And so that's been a little bit of the challenge. I mean, and that jury is not fully out if troponin I is a better cardiac biomarker than troponin T. And either way, I think it's the degree of elevation. So that has been shown again and again. If you have significant elevation, some say more than 32 of the upper limit of normal, but where do you want to draw the line? If you have, I mean, you get the smell in your nose. If you have severe elevation, that's a marker for adverse outcomes as well.
So let's say I smelled it, I diagnosed it. Now, what do I do for this patient? How do I treat them? What do I need to do and be thinking about so that we can stop it or even reverse the process?
Yeah, right. So if, I mean, there's been, as you can imagine, a debate around this as well. I mean, some say, well, I mean, do you really want to give steroids to everyone? Because that's been sort of a reflex, right? I mean, you see, I mean, it's like you see a snake in front of you, you get the revolver out and just shoot it. I mean, is it the same here? And then, or some would say, you just give one high dose methylprednisolone, one dose, and just have to continue the workup. Others would say, as the guidelines do recommend, you give at least 3 doses, so 3 days or 3 to 5 days. I mean, you really try to silence that immune response. Now, unfortunately, there are some patients who are steroid resistant. They might not respond to it. The troponins may not decrease. There might not be a silencing of the arrhythmic events or other clinical manifestations. So that's usually how you gear. I mean, if your therapy is working, and then you have to revert to other means. And I think where this is happening, then, if there, I mean, any significant arrhythmias, respiratory distress, if you have evidence of circulatory failure, cardiac dysfunction, these patients, I mean, may need to, I mean, should go to the ICU, because where you feel like, I mean, this is escalating maybe potentially much more quickly. So that's definite. The other patients, telemetry unit, but then you have those two where you feel like, I mean, this is, I mean, myocarditis. I mean, we do these steroids, and then you just linger, and people ask, can they be also managed outpatient? I mean, some patients will even refuse. Sure, you might not believe it, but some patients refuse to go to the hospital. They say, I'm not convinced I feel well. I mean, I have a biomarker elevation. You think I have myocarditis? I mean, but what? I mean, so they're really in the river with the crocodiles, but they don't worry.
It's true, because many of these folks have been in the hospital so many times
Right.
and they're not going to go just because a blood test is abnormal, right? I mean, there's a resistance to being a sick person, especially if these drugs have been helping them, right?
Right. Exactly right. And so if you feel like with the steroids, I mean, you keep them in check, literally, for these checkpoint related events. If that fails, then other immunosuppressive agents, right? So everything has been tried. We don't have any randomized clinical trials published or available that will guide us one way or another. There are 2 efforts, though, in place. There is a study undergoing in Paris, and there is a study here, which we're part of, the Atrium trial. It's with abatacept. So that's a CTLA-4. I mentioned this earlier, and I mentioned it on purpose because it's a CTLA-4 Ig fusion protein. So it's a large molecule that's administered, and it's a decoy. So it's a CD80, CD86 decoy. So that keeps the T cells sort of in an energetic state, because I mean the receptors are occupied, so they cannot have the CD28 mediated co-stimulation. So then, it just keeps them at bay. It keeps them at check. The problem with abatacept is it's a large molecule, the distribution and so forth. It takes time till it really comes to full effect. And so what the group from Paris has published is that in these patients who also have, concerns for grade 3 or higher, so clinically very relevant events, plus respiratory distress and so forth, you're worried about abatacept plus a JAK inhibitor, ruxolitinib, and that's been used in rheumatoid arthritis. So that's something to dial down the T cells as well as a quicker onset. So that's been tried, and so they're looking into this in Paris further. Our study here that Tom Nealon is leading from MGH is just abatacept, and they get multiple doses for patients with immune checkpoint inhibitor myocarditis. There's also a rescue arm. But that's sort of, I think, what in terms of evidence base, that's where something is emergent. otherwise, you can do whatever you would do almost like for a transplant rejection, acute rejection, right?
You're just going to throw everything at it, right? In a sense, and hopefully have somebody like you who can be coaching us.
Yeah.
So let's say their arrhythmias have settled down, their biomarkers are dropping. This class of drugs was working for them. Their tumor was stabilized or regressing. Can we consider ever starting an ICA again?
Yeah. So it's between you and the patient in a way, right? So we're in this triad, then we have the patient, we should be in the center. We have the oncologist or hematologist, and then we have the cardiologist, and it's sort of like a joint, decision. What do we advise? And we've been in these scenarios. A number of people have, and true. So, if you have a clinically relevant event, common guidance would be not to resume them. If you have, myocarditis and if you've had that diagnosis, if that's the only drug that's left, do you again jump into the river full of crocodiles or do you not, right? They came really close, but do you still have a chance there? And so there have been some case reports on rechallenge in patients with myocarditis. There was one last year from the group in Zurich, and so what happened? What you assume would happen? They had another immune response, and this time it was more aggravated than before, but no clinical events. But still, I think it's really in that scenario. And going back and forth through these flares of myocarditis, then there's silence, and this can't be good. We don't know yet at this point what is the long-term sequel. The duration of this, number one, what we've seen, depending on the extent of myocarditis, it can take several weeks, several months even for it to fully silence. If you followed cardiac troponin level, we followed patients on PET, like a sarcoid protocol PET. That's something like someone might entertain as well. And so we've seen that it takes quite some time if you have significant myocarditis to fully resolve. And I don't think it's not imaginable in a way to just to resume immune checkpoint inhibitor therapy if you're still in that state. And I think it's really, the risks and the benefits at that point. I think it's really, but the patients, you're absolutely right. The patients will ask you, in essence, what do you want me to die from? My cancer, right? Or the adverse effects of the therapies, and that is so hard. And I think for us, it's really the mantra: first, do no harm. I think we feel bad if because of the therapy we've provided, we've accelerated something. So I think that's really ethically, it's really challenging.
Are there other cardiovascular side effects that we should be aware of other than the myocarditis? You sort of mentioned just heart failure without inflammation. What are the things that we ought to have also in the back of our mind when we're called to see this sick patient on the oncology floor or in the outpatient?
Yeah, so if it's truly not myocarditis, by any means available to make that diagnosis, including, or excluding it, but cardiomyopathy, that's really, the next thing with the heart failure, a decrease in cardiac function. Takotsubo's, you would assume, it has sort of a classic presentation. It would sort of declare itself in a way with resolution, and we've seen that. Other cases where it's a little bit more persistence, and then you do the standard guideline-directed medical therapy for cardiomyopathy and hope that they improve. Now, the insight from the group in Essen who's worked on this was that TNF-alpha inhibition has helped. Now, that's another, I don't want to go there. We've been there. Patients with heart failure, shall we do those kind of therapies? But maybe this is different. So this is something where we need the basic science to guide us, the translational science to guide us. And so there's a lot at work in this area. The problem is that these rodent models that are used, that they're not perfect. That they're really difficult. It's really difficult to create that same scenario in an experimental model so that we can learn. But I think we're going to be prepared to be creative, just like I've mentioned about abatacept and the JAK inhibitor in the future. I mean, to maybe have new channels of therapies, but for the time being, it's whether it's the right thing or the best thing to do, I should say, we just what we always do in these scenarios. But I think we'll need to see. And then going to the atherosclerosis, the coronary artery disease, that's a debated topic too. And so Tom Nealon will tell you that, I mean, it is an important topic. We've seen that, I mean, after you start immune checkpoint inhibitor therapy, these cardiovascular events will really double, if not triple, and so forth. But we haven't seen it here. That I have to be honest. I mean, actually, we've seen less than what you imagine, because if you think about atherosclerosis as an inflammatory disease, you think given immune checkpoint inhibitor would be really pouring oil into the fire. But I mean, we haven't seen MIs left and right or strokes left and right. We just haven't. But this being said, there still might be a subset of patients who will experience this acceleration of atherosclerosis. So statins, high-dose statins, and he in the report that they've published, Tom Neal and his group, statins seems to be somewhat beneficial. Steroids, I mean, and you're almost dealing like an arteritis, right, like a vasculitis scenario. And there have been large vessel vasculitis reports as well, aortitis. So I think calling your friend in the rheumatology department might also be something to consider for some of these cases.
So is it too much? Is it too far to go to say that these folks with maybe cardiovascular risk factors at baseline or known atherosclerosis, should they all be on statins? Is there a role for aspirin? I mean, where are we going in the future with either prevention of this from ever happening or modifying the risk?
Yeah, I mean, that's an excellent question. And again, I mean, so debated. I mean, because it's really hard to pinpoint. There have been various risk factors postulated when you look at the ESC guidelines. We put in there cardiovascular risk factors. It's maybe more conceptual, hasn't been fully proven. Some say women are at a higher risk. But that's again, maybe just one or two studies indicating that. But I would say it can't hurt. We're cardiologists. We love statins. I love statins. I'm not taking one, but I love them. And so I have no disclosures either. But I think that's definitely just makes sense. Even apart from that's often in cardio-oncology, the theme as well, apart from the cancer therapy, if you have, the setup, it just makes sense to be on those drugs. Now, aspirin, we don't know as much. Now, there's not only the arterial events, there also is venous thromboembolism. And if you look at the oncology literature and guidelines, they do comment on this as well. So immunothrombosis, the whole thing with inflammation and stimulating thrombosis. So that is a theme there too. So these patients, they can have thrombotic events as well, and they're more prone to it with the inflammation. So something to be aware of as well. Now, preemptively, no one really does anything. I would say preemptively, the oncologists, hematologists don't even want to know about it, right? They just, as like, it's not so easy. How do we, and then again, back to the surveillance, that's not commonly done. And we can imagine this possible scope of it, right? How do you want to preemptively or proactively monitor for any possible side effect with these drugs? The cost effectiveness is just not there. And then I think so it's just, healthy lifestyle recommendations. Patients who meet the indications for those cardiovascular medications should be on them. And then how do we, in terms of, those who we need to see early on, yeah, I think that's evolving. At this end, we're sort of in a reactive mode, but I think I agree with you. Ideally, in the future, we'd like to be in a more proactive mode.
So my last question, should every patient who is started on one of these drugs be seen by someone like you in a cardio-oncology clinic? Or is this uncommon enough that that it would be, kind of a referral after the diagnosis. And I realize there's no right answer to this, but in today's world, what would you say to that?
Yeah, so it's the volume question, right? So there was, and there might still be, Sharon, a legitimate concern that we don't have enough patients for all the trials that folks want to do with immune checkpoint inhibitors. And there was one estimate, I mean, how many patients in the US would be eligible for an immune checkpoint inhibitor? They're estimating maybe 50% of all cancer patients. So that is a huge number. And I mean, it's really expanding. And it's just not manageable. It's not practical to see everyone. But yeah, who do you want to see? And I think so. Those are the ones who had cardiovascular events. There are sometimes these scenarios where patients had some recent decompensation of their heart failure, where they have a cardiomyopathy to begin with. They had a recent MI. They have some other setup for potential complication. I think those ones would be the ones to see where I feel like. And other than that, though, it is still, more in a reactive mode. Whenever, they have, these manifestations that we get pulled in. And so I think that's for every, general cardiologist. I think we said in the beginning. We all need to be ready. These drugs, if you think about 50% of all cancer patients in the US potentially eligible, and then even if you just have 1% of these millions of patients, we still have a lot to deal with.
We have a lot to learn. And obviously, as the use of these drugs expands, we'll have a lot more, we'll get a lot more practice. And today you have really shared some very practical things, but also the extent to which we still don't know and shouldn't be dogmatic about treatment and diagnosis. And we all need to stay tuned. Is that right?
Yep, absolutely. Stay tuned. And for those who are interested, we have a Mayo Cardio Oncology CME course. It's in Arizona. Mayo's Clinic Scottsdale is hosting it, if you will. And that's on November 7th this year. And so we'll be talking about immune checkpoint inhibitors and their adverse effects some more at that meeting.
Well, thanks for that plug, because I'm hoping those who you have piqued their interest, they will choose to join you in Arizona. Thank you so much. This wraps up this week's episode of Interview with the Experts. I'd like to thank Dr. Herman for joining me today and discussing this really important topic.
Thank you so much again. Yeah.
We look forward to you joining us again next week for another Interview with the Expert. Be well.